Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Ipsen.
This program is presented by Medscape Education Global.
Hello everyone, dear colleagues. I would like to welcome you to the Medscape Global Oncology Program, sharing expert minds in lung cancer and lung neuroendocrine tumors, delivering optimal patient care. My name is Martin Reck. I'm working in the north of Germany, in the lung clinic in Großhansdorf, very close to Hamburg. And it's my pleasure to introduce my faculty, Professor Marianne Pavel, who's a professor of medicine, the chair of endocrinology at the University Hospital of Erlangen in Germany. And it's also my great pleasure to introduce Catherine Bouvier, who's the CEO and co-founder of Neuroendocrine Cancer UK, and who's the International Advocacy Committee lead of the Neuroendocrine Cancer Alliance. Welcome both to you. So today we will talk about the burden of living with lung NETs, and we will hear a lot about clinical trial data with targeted therapies for this disease of lung NET. We have to be aware that this is a complex situation. It's a rare disease, and we are entering a couple of different subtypes. So on the one hand, we have the neuroendocrine tumor, the small cell lung cancer, but then on the other hand, we also have the neuroendocrine tumors and the neuroendocrine carcinoma, and the question of an appropriate diagnosis is very, very important. We are talking about rare diseases. Therefore, unfortunately, the awareness for this disease, in particular the awareness for lung NETs, remains very long among lung thoracic specialists. On the other hand, we do see a rising incidence. The problem is that we do not really have very clear characteristic symptoms of the disease. We do see unspecific symptoms. We do see a variability in the natural history. Therefore, the clinical diagnosis of this disease frequently is very, very difficult. On the other hand, we do need a very accurate and early diagnosis of this disease in order to ensure the most effective treatment for our patients. Histopathology and accurate histopathology is key for a very good and very appropriate treatment. It's very difficult to make the diagnosis based only on one marker. So we really need a panel of different immune histochemical markers. We need to standardize our immune histochemical markers to differentiate the different lung neuroendocrine tumors to make a correct distinction between lung NETs and the lung neuroendocrine carcinomas. Besides that, diagnosis is also very, very important. We can have an impact on our patients by misdiagnosis of this disease. We are talking about anxiety and distress. We are talking about a psychological trauma and an impact on quality of life. We are talking about a delay of treatment and a worsening of the health status. And we are also talking about financial burden and the loss of trust in our healthcare system. So we have, on the one hand, the question of the appropriate perception of the disease, of the accurate diagnosis, the histopathological diagnosis, and on the other hand, we do have the problem of the patient who is suffering from the disease and who has to work with the disease. And therefore, I would like to introduce Catherine Bouvier, who will talk about the patient's perspective of people who are living with this disease.
Thank you, Martin. I think from the patient perspective, the lack of recognition, the lack of education, and the lack of a timely referral really into an expert multidisciplinary team, even if just for an opinion, when considering sort of 3 of the 5 subtypes of lung neuroendocrine tumours and lung neuroendocrine carcinomas, so under the umbrella simply of lung neuroendocrine tumours. I think this is a really key factor in leading to misdiagnosis and late diagnosis for this patient group. Martin has already highlighted the impact, and I would just like to reiterate that this really must not be underestimated. Terminology around the subtypes is also challenging and has our community believes led to an unfavourable attitude around the validity of the cancer type. And I think I have too many stories of people being told, don't worry, it's not really cancer, leading to misinformation too. This has also impacted some people not receiving the proper workup, the relevant scans and bloods, etc., and also not receiving relevant follow-up protocols, especially after an assumed curative treatment. I think the reticence to see the typical and atypical lung neuroendocrine tumours as a cancer type, having a malignant potential, has also led to late referrals into expertise, and many experts seeing patients with more advanced disease, metastatic disease, by the time they see them. Now, we know for all cancer types that a timely diagnosis has a huge impact on quality of life and on outcomes. The stories of misdiagnosis within the patient community are quite extraordinary. From a diagnosis of a completely different primary, which was in fact metastatic disease from a lung neuroendocrine tumour primary, to diagnoses of adult asthma, to diagnoses of a non-cancerous tumour or node that was seen on a lung X-ray. And in some cases, and quite sadly, a diagnosis of stress or anxiety, which certainly is going to be compounded by not being listened to when you feel that something is wrong with you. We get comments around treatment options in the lung neuroendocrine cancer space. There are requests often to understand what work is being done to understand the cause, for example. We know there is published data, as has already been alluded to, potentially showing a higher proportion of diagnoses in women of a younger age and lifelong non-smokers. And so understandably, if you're that person, then you want to know why you have a rare but steadily increasing cancer type. There is certainly an unmet need in the lung net community, perceived by both the expert HCPs and the patients and families. And I think we mustn't forget many people quite rightly take an awful lot of time to invest in understanding their disease and treatment options. And data, information and research is often there for those who want to know more. And I think the expert patient is more and more common. So I think for healthcare professionals, there is nowhere to hide, and nor should there be. This community deals with a rocky road to diagnosis, a struggle with terminology, a fear of the future, I think, especially where experts are not involved in their care, and certainly a frustration around the lack of recognition of their cancer type in both the research arena, but also in the field of thoracic medicine. Let me now introduce you to Melanie and Professor Mansour. Melanie is living with neuroendocrine tumour, and she has had a journey riddled with challenging misdiagnoses. Professor Mansour is a consultant medical oncology and the lead for the lung neuroendocrine service at the Christie Hospital in the UK.
Soon realised the benefits of even just spending 10 minutes a day just walking around, talking to the plants. It just brought something really magical into my life, and the more time I spend in the garden, the happier I am. At the beginning of May 23, I developed a cough. It was non-productive. I was starting a new job a month later, and I'd had it for a couple of weeks. So I thought I'd better get it checked out by my GP. Yeah, so I had X-rays and the CT scans, and the doctor called me with the results of those the night before he went on holiday, thankfully. But he did say that it was lung cancer. and the staging was suspected at 2B3, and more tests were going to be needed. He spent, quite a bit of time giving me information around who I could contact if I needed support at this stage. And I just kept asking, are you sure it's lung cancer and it's not a cyst? But he was very absolute in the fact that it was lung cancer. I then realised, oh my God, and my heart was just breaking over and over and over again. Every time I looked at my husband, I literally just fell into 100 pieces inside. I still do, but not so intensely anymore. But literally, I did find him really hard to be around. I wanted to not be away from him, but every time I looked at him, I just crumbled to pieces. And I just missed him already, even though I would be the one going. And your own sort of mortality flashes up in front of you. You kind of feel numb, grey, and it was just the start of a really intensely grey, colourless period in my life. Yeah. So my GP sent me to the specialist lung team, who then referred me on to have a biopsy to be able to confirm the diagnosis. And throughout these appointments, there was lots of language change, which was starting to make things become quite grey and quite confusing, different terms for cancers, for the tumours and the like. And the first time any kind of doubt was sown was when I saw the radiologist, and he said that there's something there, but I'm not sure it's lung cancer, but there's something there. The biopsy will help us get to the bottom of that was, and he explained, why he felt the way he did as well. And that was kind of the first time that there might have been a sort of a subtle shift in what they were seeing that was presented to me, and it was quite hopeful, I suppose, a small glimmer of hope in there.
There are two things that we as clinicians have to get right. We have to firstly get right the grade of the cancer. So is this a grade 3 cancer, so a poorly differentiated bona fide lung cancer that people treat, or is this a neuroendocrine tumour, which we regard as grade 1 or grade 2, so well differentiated. So that's the first step. The next step is to make sure that once we've got our neuroendocrine tumour, is this grade 1, so typical carcinoid, or is this an atypical carcinoid? Because the treatments are different sometimes, okay? And so there are two steps that we have to get right. From the patient's perspective, what we have to get right is the treatments, obviously, that they're going to go on. And so that relies on the bedrock of oncology, which is getting the diagnosis right.
When the biopsy results came back, the lung nurse called to tell me, as she said, with great relief, it's not lung cancer, it's something called neuroendocrine cancer. And then she went on to explain, very brief, very top level, but in a very reassuring way, what that meant. But again, it was very top level information, and she was at great pains to kind of say it's low grade, it's slow growing, and we're now going to get you to see a specialist, a neuroendocrine specialist. And when I did get to meet him, that was, I kind of guess, the start of this next phase of my journey, really. And I'm still really, really confused around all the language. Multiple words to describe the same thing. To us laymen anyway, it might mean something very different to those in the know, but the language has probably been the hardest thing to get your head around in this strange, rare cancer. So, and I'm really, really thankful that I had my job, my gardening job to go to, and it really takes you out of that space. And then every now and again, have to go and run into the hedge to have a cry.
Wow, this was very impressive to see really this personal impact of the disease and the complicated diagnosis and all the impact that you might introduced with a wrong diagnosis or a misleading diagnosis. So we have learned a lot about this very, very personal view on the disease. And now I would like to introduce Marianne Pavel, who will give us an overview on the treatment opportunities and more importantly, on the novel treatment opportunities that we do have in the treatment of these different type of NETs and neuroendocrine carcinoma. Marianne, please.
Thank you, Martin. I would like to pick up again the clinical challenges. Some patients may present with hormonal hypersecretion that may not be recognized by the physicians. On the one hand, this is a carcinoid syndrome. Around 10 to 30% of patients suffering from lung carcinoid have this syndrome, characterized by flushing, diarrhea, or even wheezing. And around 5% may suffer from Cushing syndrome. But on the one hand, we have the typical carcinoid that is often indolent, slowly growing, mostly somatostatin receptor positive. And on the other hand, we have the atypical carcinoid that is moderately to aggressively growing, but it's still much better than the small cell lung cancer. However, patients are often treated like lung cancer patients, or they are frequently offered first-line platinum-based chemotherapy, what is not an appropriate treatment for these well-differentiated neuroendocrine tumors. These tumors, however, may display variable tumor growth, and that requires an individualized treatment approach. And often patients are not offered somatostatin receptor imaging, and imaging that is available, the functional imaging, is somatostatin receptor PET-CT. And this is crucial to assess treatment options, because one of the treatments that we use is somatostatin analogs or radioactive compounds that are labeled to somatostatin analogs and bind to the somatostatin receptor. So it's really important to assess if somatostatin receptor expression is present on lung carcinoids. But often these patients are offered FDG PET-CT scan instead, like lung cancer patients, but that may be negative frequently in typical carcinoids. So how do we manage neuroendocrine tumors of the lung, the typical and atypical ones? There is few established therapies. It's widely understudied, and the treatment follows recommendations that we have established for GI and pancreatic NET. We learned a lot from non-lung neuroendocrine neoplasm patients, and much of these considerations are also applied to lung carcinoid patients. In fact, it requires an interdisciplinary approach, taking into consideration these different features. This includes the pathological features. We need to ask about the mitotic count. Are there any mitosis? How many mitosis? And Ki67, is the somatostatin receptor expression homogeneous? Is it heterogeneous, or is it even absent? The growth rate matters, and sometimes you only learn about the growth rate if you do repetitive imaging, the CT scan of the thorax and MRI of the liver. And it is important also to include the whole body assessment to understand the disease extent, because also local regional treatments could be delivered to the liver, particularly if a functional syndrome is present, then there's an urgent need to control the syndrome first. If you look at systemic treatment options overall, then somatostatin analogs is the first-line treatment. It's octreotide LAR and lanreotide autogel present on the market. The only compound is everolimus, an mTOR pathway inhibitor that has been widely studied in the field of neuroendocrine tumors and also in lung carcinoids. And there's a pivotal study that led to registration of everolimus was a RADIANT-4 study published in Lancet in 2016. In fact, this study showed prolongation of progression-free survival that was in median 11 months with everolimus and 3.9 months with placebo. There had been other studies in lung NET. I just want to mention the LUNA study that support the everolimus activity in lung carcinoids. PRT, peptide receptor targeted therapy, or radioligand therapy, is an emerging therapy in lung NET. It has been used in Germany for more than 20 years already, but no prospective studies had been performed so far in lung carcinoids, so it's an off-label consideration. Other compounds in use for lung carcinoids include temozolomide, with or without capecitabine, and platinum-based chemotherapy like FOLFOX. These data come from small prospective phase 2 studies or mostly retrospective studies. It is crucial to manage the syndrome first. If a patient suffers from carcinoid syndrome, the approved treatment to control symptoms of the carcinoid syndrome, irrespective of the primary tumor site. Most often it's a small ball net that are associated with carcinoid syndrome, but as I mentioned initially, patients with lung carcinoids may also suffer from carcinoid syndrome. Then there is no doubt that we need to initiate somatostatin analog treatment. And for the patients suffering from Cushing's syndrome, we have several compounds available that inhibit steroid synthesis and cortisol production in the adrenal glands. If you look at the antiproliferative treatment, of course, we always consider in typical carcinoids that are very slowly growing SSA upfront. In some patients, we even consider a watch and wait approach if the tumor burden is very low and the disease is not resectable. Of course, this will always be considered even in advanced disease if the tumor can be removed completely. If in atypical carcinoids, in 50%, the somatostatin receptor expression is not sufficient or even absent. So we can't apply these treatments like somatostatin analogs. If patients progress with typical carcinoids or atypical carcinoids and SSA has been exploited if feasible, then everolimus is a treatment of choice based on the only registered compound. And another treatment that is widely used is temozolomide-based chemotherapy. So it requires a multidisciplinary team approach to consider what is the best treatment beyond everolimus in these patients. The data on PRT, what can we achieve and what did we learn from retrospective and small phase 2 prospective trials? The objective response rate ranges between 13 and 30%, and the median PFS between 11 and less than 30 months. So it is important to note that we have now 2 comparative trials of PRT versus everolimus in somatostatin receptor positive thoracic carcinoid. So in the future, we will learn more about the value of PRRT in the management of lung carcinoids. I now would like to highlight the cabinet phase 3 study that has been shown at ASCO and ESMO these last 2 years and has just been published last year in the New England Journal of Medicine by Jennifer Chan. It's a US study looking into the efficacy of cabozantinib versus placebo. And the cabinet phase 3 study was a placebo-controlled study in extrapancreatic neuroendocrine tumors. The vast majority had been GI NET patients, but more than 20% of the included population was lung or thymic NET, and also some patients with unknown primary were included. This study showed a prolongation of progression-free survival. It was less than 4 months in the control arm, and it was 8.4 months with cabozantinib. So the primary endpoint of prolongation of progression-free survival was met by this study. This compound is now under consideration with EMA and FDA for registration. And there is much hope that we will have this compound available in the future treatment landscape in the field of neuroendocrine tumors. So you may wonder, what is the role of immunotherapy? And there are some small uncontrolled studies that had been rather disappointing. And there was also one study, an international study, where also Europe was included in Germany with batalizumab, and it looked in different cohorts of patients, GI, pancreatic, lung carcinoid cohort, and the highest response rate reported was indeed in the lung carcinoid group. It was 17% objective response rate. This may not look very high, but there is some signal of activity in a subset of lung carcinoids patients. Unfortunately, there was not a subsequent trial looking into efficacy of immunotherapy in lung carcinoids. So we need more data to understand who might benefit. Altogether, I may summarize that we need international collaborative efforts to extend the treatment landscape, also not only restricted to immunotherapy to understand where there may be the value for the management of lung carcinoids, but in general for the field of neoplasms.
Thank you, Marianne, for this comprehensive and very exciting overview on our treatment opportunities that we do have for patients with NETs and neuroendocrine carcinoma. I think this is really an evolving field. Now we have time for some questions, and I would like to ask Kathy, you have heard about all these new treatment opportunities that will come into our hands that will offer benefit to the patients. My question would be, how important is it also to educate the patient about therapeutic opportunities for this disease of NET?
Thank you. I mean, in short, it's an extremely relevant role. And it's based around communication, isn't it? And communication around the therapy and details of potential side effects, strategies for dealing with those side effects, contacts for queries, if you have any as a patient or a family member, are vital around any treatment. And of course, alongside true consent, because without that true education, then you're not going to get true consent for either for a trial or for any new therapy. Just handing out a leaflet without discussion is really not an optimal way to go. Going through that information and giving time for questions will ensure not only adherence to treatments and also protocols for follow-up, etc., and adverse event monitoring, but most importantly, will give the patient confidence.
I think the balanced information also, the information about potential other opportunities is extremely important. And we will come to this in a minute. Marianne, you talked about the new field of therapeutic opportunities that we do have. Where do you see the most important challenges to bring new treatment approaches into this disease or into these diseases?
Yeah, I think first of all, cabozantinib and PRT are the emerging therapies that will, with registration, being more available and could be accessible to patients. And the immunotherapy is still an evolving field that is individualized decision making. But I think it is really crucial that the patient is referred to a center of expertise. And I think upon the diagnosis, it is crucial that the patient sees a specialist with experience on managing the disease to really pave the appropriate way. I think education, that this is a disease that is rare, that requires a high level of expertise. And we don't want to keep the patients. We like to collaborate with oncologists, but I think the decision-making in an interdisciplinary team is really crucial.
So I think we need the early contact with highly specialized sites, as you mentioned, at least for the first treatment decisions. And you mentioned earlier, we also need a quite high level of standardization and diagnosis. Sometimes we are mismatching different tumor types in our trial population. So there's a lot of things to be done in standardization to get the correct picture of efficacy in the correct group of patients. Well, Kathy, you mentioned that education is very, very important in getting the patient along with a new treatment. Something that we have now introduced, I think this was a good idea, is a term that we call shared decision making. And I think my understanding is of shared decision making is to take the patient into the decision about his treatment, about the treatment of his disease. From your experience, what is the largest barrier to this shared decision making between the physician and the patient?
I think it's quite a complex area, if I'm honest. And I think if I start with a one that we hear about a lot, I think it's to do with the different roles between the patient and the physician, doctor, oncologist, surgeon that patient might be seeing, and the relationship that has developed between those two people. A positive relationship is probably the most effective way of ensuring shared decision making. And that requires, I think, a shift in attitude certainly from, the doctor knows best to I am here to provide you with the best care I can, and I want to help you to decide what you feel is the best option for you. And I think that kind of the nothing without me slogan, nothing about me without me slogan, I think is a strong reminder of this. But communication is always, it's a two-way street, and it's something that we do a lot of work with our community, discussing the best ways to get the best out of clinical appointments, for example. But we mustn't forget there are also cultural and educational and language barriers that need consideration, alongside the way we communicate, even with our body language, something that we don't think about very often. But, these can be just as positive or negative. You can certainly emit feelings of sort of superiority or disinterest or frustration and fear, really, through body language. And again, like the first question, I think it comes down to communication. Honest and open conversations is vital, because I think without that, considering all the other barriers that are going to be there, you will never get to a true shared decision-making scenario.
So a true communication is key. Marianne, you are seeing a lot of patients every day. What's your way to handle this problem and to get into contact, into a true open contact with patients?
I think we need to be dedicated to offer enough time to the patient. And this is also the strength of the center. We have more time than private practitioners, oncologists that have to see a lot of patients one day. So happily at a university clinic, we still have some more time we could dedicate to a patient. So I take a lot of time to explain them the disease. For them, sometimes I offer them a whole new world, particularly if they come with a lung cancer diagnosis, to explain them that they have more indolent disease, as we have understood from the patient case. So patients, we can take them their fears, but also explain the treatments. And also, if we decide between two treatments, should it be TKI or everolimus, we need to address all the comorbidities. And it's also some preferences. If we talk about chemotherapy or PRT, some patients fear the irradiation, some fear the chemo. So we can explain them that's not so toxic chemotherapy like in lung cancer patients. But of course, this needs a lot of time. If it's related to a certain compound, we have a pharmacy that provides support to explain more the side effects. And then we have a patient support group. For example, I have a patient that has a lung carcinoma with stage 4 disease that is surviving 30 years. And he's very willing to help patients. They can also have leaflets to read about the disease that are either provided by Inca or also, and they are also translated into German, of course, so easily understandable. So I give them some information that they can read, and for the next consultation, they can come back with some more information that they have read through themselves. But not everybody is so keen. Sometimes patients are overwhelmed and they say, you have to decide for me, and you can't put this on me. So it's really depending on the individual needs of the patient and how far he is willing to get into the details of all these treatments.
Yeah, so I think time is very, very important. And I think there indeed you are in a lucky situation that you are working at a university hospital. You have got some more time that you can spend together with the patient. But I like your beautiful idea also to take patients into this dialogue about the treatment opportunities and also the perspectives that they might get with your therapy. So we are already at the end of our time. It has been a marvelous discussion. Kathy, I would like to give the last question to you. So we have seen the video of the patient. We have talked about therapies, but I think more importantly, before we talk about therapies, we need to diagnose the disease, and we need to diagnose the disease very appropriately at an early stage. And we have a lot of misdiagnosis, late diagnosis of these rare tumors. So what can we do to raise the awareness for this disease, to raise the awareness for an appropriate early disease of lung net or net tumors?
Yeah, I mean, I think when you've worked in this field for quite a long time, it can feel like quite a frustrating question, because, the disease and the information about this disease is certainly widely available on our global network. So I think we have to change our approach to raising awareness. I think it's really key to do that so that we can gain engagement outside of the expert neuroendocrine community. We need to change perceptions around neuroendocrine tumors and neuroendocrine carcinomas and what they are, and get a true understanding of the impact of this disease on patients, irrespective of the stage and the grade, and the way it behaves in terms of its aggression. I think we need to feed into general education and awareness activities, around neuroendocrine tumors. I think into lung cancer arenas, reaching out to that community and making sure that the neuroendocrine subtypes are included in the discussions around lung cancer, because it's a big community, the lung cancer community. So I think there's a great opportunity there. Obviously, we have to highlight the distinct differences, etc. We need to publish data, and more data. And I think we also need to find out how healthcare professionals learn in different countries, because I think that's a really important way for us to engage people outside of the neuroendocrine world, and show them a little bit more and provide more information about neuroendocrine tumors and carcinomas.
Thank you. I think these are great suggestions. So, Kathy, Marianne, this has been an outstanding discussion, outstanding presentation. Thank you so much for this very comprehensive and current overview. It has been a pleasure to be on this program with you, and I would like to thank you for your attention.
This program was presented by Medscape Education Global.